Hello, coders. Today we're going to talk about the general surgery guidelines and how we generally find our surgical codes. So the first thing is surgery is the largest section. Now, you can tell by the book, if you just pick up the surgery section, that it is larger than the rest of the book because it goes from code 10021 to 69990. We start with a general fine needle aspiration and we end with an operating microscope. And every body system and possible surgery that we do is in there. Now, they are then divided by what we call subspecialties. So these are our body systems. We have integumentary, musculoskeletal, respiratory, cardiovascular, hematic, lymphatic, mediastinum, and diaphragm. Then we go to digestive, urinary, male genital, female genital. Then we go on, we do endocrine, nervous. Then we have the eye, then we have the ear. Okay, and that is all surgery. Now, there are some notes at the beginning of the surgery section in the green guidelines, but those are general notes. What we do is we look at the notations and the guidelines inside of each surgical chapter. Very similar to ICD-10, where we have our general outpatient guidelines and then our chapter-specific guidelines. This is the same. So the general surgery guidelines go for all of surgery, but then there's going to be individual guidelines and notations that we're going to be going through. So the first thing that we need to know is that, remember, every year we're going to have new codes, we're going to have revised codes, and we're going to have revised text. So we're going to see a lot of things that look similar to this. In the version of your CPT book, the bow tie arrows will be green and the text will be green. Now, when we're talking about revised text, they could be adding a word, moving a word, adding a statement, giving more information. So anything that's green, you always want to make sure you read, because when you sit for your credentialing exam, about 10 to 15% of that exam is about things that are new in the code books. So when we get to surgery, surgery is the section. The body system is the subsection, and you can tell this if you look at the top of your CPT book, and if you open up to any page in surgery, okay, you'll see at the top of the book, it says musculoskeletal / surgery, and that's how you know what section and what subsection. So I'm just going to randomly open to a page right here. I'm on page 215, and it says surgery, cardiovascular system. Section is surgery. Cardiovascular system is the subsection that we're in. Now, again, at the beginning of each subsection, there's going to be notations, and then there's going to be notations before different sets of codes. Keep in mind, these notes do not apply to the entire book. They only apply to the code set they're talking about. And so, for instance, on page 215 in your code book, there's a set of guidelines specifically for combined arterial venous grafting for coronary bypass, and that is just for the set of codes that comes afterwards. And so as we go through all of our notations, keep in mind, those guidelines are only for that area. Now again, there's going to be a subheading. The subheading is usually the specific anatomic site. So in this case, if I go back, I'm going to find that this is going to be under, and I'm just going all the way back, the last subheading. This is going to be under heart and pericardium, because that is the procedure it's under. Now, I had to flip all the way back to page 201 to find that, but I'll tell you how I found that. In general, the larger red writing in your code book is going to be your subheading, okay? So again, getting more specific to the type of coding that we're doing. The category notes are the specific area that we're in. So again, page 215, the specific category notes are the combined arterial venous grafting for coronary bypass, and the notes happen underneath that, okay? So again, There is a breakdown of the CPT book, but I don't want you to get too hung up on this breakdown. This is just showing you there is a rhyme and a reason to this. This is what we call taxonomy. There's a specific order that things go in. And so again, this is going to, you'll see through the book that you see the same flow. Guidelines, codes, guidelines, codes. And those guidelines are for those small sets of codes. Now again, this is how we know where we are. So again, at the top of the page, it says surgery. This one says digestive system. In this case, the subheading is the abdomen, peritoneum, and omentum. The category is repair. The subcategory is hernioplasty, herniorrhaphy, herniotomy, and the notes are underneath. Now, when you see something like this, I do not want you to get concerned. In general, no one is ever going to ask you to find a category or a subsection or a subcategory in your book. You're never going to have a boss come up to you and say, what category is this code under? Okay, but you should understand the structure of the CPT surgical section, that there is a structure that goes through. So every body system follows the same structure, even if they have different information. And again, medical terminology is the most important. If you don't know what the word means, you should look it up. So if you have a small medical dictionary at home, if you have your medical terminology information from a previous class, or if you just use an online medical dictionary like medilexicon.com, you want to know what these things mean. And again, remember, you can write anything you want in your code books. So if you need a reminder of what herniorrhaphy means, write it in the code book. Remember, anything physically written in the code book is fair game for any credentialing exam. Now again, there's going to be also notations that happen under some codes in parentheses. We always want to look at what we call parenthetical information, because a lot of times it tells us we can use this code with these codes, or do not use this code with these codes, or it gives us information about a specific modifier or a radiology code that pairs with it. So we always want to look at the notations under the codes to make sure we're in the right place. Again, unlisted procedures, these are, there's a big list in your green surgical guidelines at the beginning of the surgery section, and then you can find them usually under the term unlisted. But keep in mind, in the field, we do not bill out unlisted codes unless there is not a Category 3 code that we can bill for, and the doctor has written a special report describing why they had to do these specific services. And again, this is an extra written report on top of the surgery, and it's done on a case-by-case basis. The insurance company may or may not pay for this. Now, you're going to see the word separate procedure a lot, okay? Separate procedure means that that procedure is usually bundled into a larger procedure, okay? So the example they're giving you on your screen, if they're just doing a breast biopsy, then we can use the breast biopsy code. But if we're doing a radical mastectomy, we always take a biopsy of all tissue that's not destroyed, and it gets sent to pathology. So we would bundle in the biopsy with the mastectomy. However, if, let's say, the patient feels a lump and their doctor just does the breast biopsy that day, then we can code it. So these separate procedure codes, they tend to get bundled into larger procedures, but on occasion, if this is the only procedure we're doing, we can code it. So that's really what that means. It means look out and make sure that the code that you've gotten to is not bundled into a greater surgical code for that procedure, okay? So we have to keep this in mind. And again, you're going to see these throughout all the sections of the book. So when can we actually code a separate procedure? Well, these are the exceptions. When only the procedure is performed, like I was just saying, or with another procedure that's completely unrelated. It's a different site and it's unrelated to the major procedure. So let's say, okay, let's take that mastectomy again. If we're doing a total mastectomy on the right breast, but the doctor wants to do a biopsy on the left breast, that's a different site. So we can code for both, but we could not code for a biopsy on the right breast because that will get bundled into the mastectomy. So again, it has to be unrelated or in a completely different site. And we have to make sure that that is what is happening. Now, minor procedures often do not have bundled services. Okay, so most minor procedures for things like Medicare specifically has 0 or 10-day global periods. The major global period is 90 days for all major procedures. Minor procedures are going to be things like sutures, if someone has a laceration on their skin, taking a wart off by destruction, simple procedures that can usually be done in the office tend to have these 0 to 10-day global periods. I want you to just keep in mind, Medicare has very specific guidelines. So if you are specifically going to be coding and billing for Medicare, you are going to have a lot of guideline information from the Medicare side on billing as much as you're going to have it on the coding side. Same thing goes for all insurances, but Medicare tends to set the standard and then other insurances tend to follow. So again, keep in mind that when we're coding in class, this is one component. The other component is going to be the billing guidelines when you guys get out into the field. Now, so third-party payers, insurance companies decide what is in a surgical bundle. Now, Medicare has created what we call correct coding initiative edits. You will see these throughout your textbook. And what these do is they specify what is bundled together. So what procedures are bundled together? So for instance, when we do integumentary surgery, we're going to see that the local anesthesia in simple repair is always included. That is bundled in with the actual wound repair. So we can't code separately for the local anesthesia and for the sutures. That's all included in a wound repair code. Now again, major surgical packages usually include these 3 portions. Remember, we have guidelines that tell us, again, this is part of it. This is all in your green guidelines in surgery. We also have modifiers for when one doctor performs one of these and another doctor performs others. So usually we have the preoperative, so that's going to be the visit to clear the patient for surgery, the intraoperative doing the surgery itself, and the postoperative. The postoperative starts the global period. As soon as that patient is handed off to the nursing staff for care, that is when the global period starts. And the global period will include any minor complications that the patient has. It all gets bundled together. So if the patient gets an infection from having a surgery, that's going to get bundled into the procedure itself. Now, meaning bundled, there's one price. Now, minor procedures may have no bundle. A simple biopsy might just be a biopsy and they pay a certain amount of money for it. This will vary by payer, so keep this in mind. Insurance companies have their own guidelines, so we work with coding guidelines and billing guidelines in the field. Now again, most guidelines have a 90-day surgical package. This also includes things like maternity care. Maternity care also has a 90-day global period after mom gives birth. So here's the big thing. The 90-day surgical package includes all services related to the surgery and any pre-op, intraoperative, or post-op issues. Now, if we try to separately report these, that's what's called unbundling. And that's where we get fraud and abuse from. Okay, unbundling happens when you're a student because you end up coding and you just didn't know that there's something included in a surgical code, and that's okay. But when you're in the field and you're working for someone who does surgery, your job is to investigate what is and what is not bundled into surgeries for the different insurances. Okay, so again, this is why I always say, Otherwise, in the continuing education that we have to do to keep up our credentials, this is the investigative work you will do in the field. You will have all the knowledge of the coding side. Now you need to understand the specific billing depending on where you work. A lot of you guys are on the line between the two states. If you go to another state to work, they're going to have different insurances and slightly different guidelines, and so keep this all in mind. Now, we never bundle in general anesthesia. Anesthesia, as we talked about, is always reported by the anesthesiologist or the certified registered nurse anesthetist. Those are the only people who can actually use the anesthesia codes. Now again, surgical package of a minor procedure. Again, the pre-op and post-op are sometimes reported separately, especially for things like cataract surgery. A lot of times, if someone needs their cataracts removed, the ophthalmologist will send them back to their primary care to get preoperative clearance, and then they will do the surgery in the post-op. So again, we need to know what's going on with the patient and who's doing what. And again, sometimes these can be reported separately if the payer allows it. So again, if we're doing a needle biopsy in the office, this used to happen when I worked for endocrinology. We did thyroid biopsies the fourth Friday of every month. And we were able to report the biopsy and the supply, the surgical tray. Now, the general surgical tray code is 99070, but remember, if we're using specific equipment, we may have to break out our HIC picks depending on what the physician does in the office. Now, again, the surgical tray code covers things like needles, sutures, wipes, drugs, and again, we code 99070 for most insurances, or A4550 for Medicare. So again, Medicare bundles these into the procedures. So we either can't use it or have to use a HCPCS code. So again, Medicare has their own separate set of guidelines and their own way of dealing with the billing side. Now again, we are looking at outpatient coding. So this is what we call physician payment or professional. However, some of you may end up working as inpatient coders who deal with the facility payment. The facility gets paid for the use of the surgical suite and certain pieces of equipment, like robotic equipment. But the physician gets to code for the actual procedure that they perform. And so what you will need to know, depending on where you work, is who are you coding for? Are you coding for the provider? Are you coding for the facility? Now, we have two general surgery codes, 10021 and 10022. These are fine needle aspirations. What these are is we're using a very small needle and we're grabbing just a tiny bit of whatever it is. It could be fluid, it could be cells, it could be blood from an area. In this case, it looks like she has a spot on her neck. It could be her thyroid. And what we're doing is we're going in there, and this is without imaging guidance. He's just going in with the needle and grabbing that piece of tissue. However, the most common imaging guidance they use is ultrasound, which is what we did in my office. So that's one of the things we need to know. If your provider does these in the office, is it with or without imaging guidance? Then keep in mind, who are you coding for? If you're coding for the physician, you're going to use 10021 or 10022. But if you're coding for the lab, then you're going to use either 88172, 173, or 177 for the evaluation. So always remember, who are you coding for? All right, guys, I hope that this was helpful to you. Keep in mind that, again, we're going to go through each section of surgery as we continue through the course. Have a great day.